to all. In this video, we will be discussing about uh, ECG and to go systematically, and we look for if there is any morphology or not. Since there is no any single rhythm stripe, so first of all we need to find out whether the given ECG is does fall under sinus rhythm or not. And as we have already discussed, to fall under sinus rhythm, there must be P wave positive in lead 2. So we will be looking for lead 2. So here is our lead 2, and here you can see I am drawing a circle with a red. So you see here, these are the P waves. So you see the P waves, they are positive. So one criteria it has been fulfilled. And the another criteria is that uh, every time the P wave comes ahead of QRS. So you see here, suppose let's take this one. So here it is a P wave here, and this is QRS. Here is P, and this is QRS complex. Here is P, and here is QRS complex. So similarly, if you see here, this is P QRS complex. This is P QRS complex. Similarly here, P QRS complex. So every time P is preceding QRS complex. So another that has also been fulfilled. And another thing what we can look for is basically whether the PR interval is constant or not. So we'll be looking at that. So here you see uh, two, almost like about two small square box. So the pretty PR segment seems equal. So and the PR interval also seems equal. So basically, it seems to be have sinus rhythm to some extent, let's say, and there is no AV conduction delay. That also you can rule out from here only. And the P wave morphology in lead 2 you can see it is normal. In lead B1 also it is normal. So P wave it is normal. And if we go to find the rate, so talking about the rate, uh, first of all we need to find out whether these are regular or irregular stripe. So you see here, 1 2 3, almost 3.5. So let's see, 1 2 3. uh, I think it's a bit irregular or something like that, so we need to confirm it a bit nicely. 1 2 3, here it is more than 3.5. Here it is also 1 2 3, more than 3.5. And here 1 2 3, so 3.5. So it is like almost regular. So you can use any of the formula, 1500 divided by number of small square box between two QRS complex. That formula also you can use, or you can use other formulas roughly. So here to here it will be 300, and here to here it will be 1500, here to here it will be 100, and here to here it will be 75. So the heart rate must be between 75 to 100. So which falls under normal heart rhythm. Now basically looking at the axis, if you see here in lead 1, so lead 1, if I draw lead 1 here, and this is lead 1, and let me draw AVF. So you see here in lead 1 the QRS, this is the QRS. So you see here the QRS, it is positive. So you see here, this is the QRS. So the deflection is positive, so the vector in here is positive. So let me draw a positive vector in lead 1. So let's say this is our positive vector, and you see in AVF, so this is our AVF, and you see here the most of the QRS complex it is negative. So drawing the negative vector, and the magnitude of AVF is greater than AVL. So I will draw this going up. uh, since the negative AVF is okay, the magnitude is more, so somehow like this. Now we draw a imaginary perpendicular lines. So basically here is our one imaginary perpendicular line, and here is another imaginary perpendicular line, and when we draw the resultant, it forms somehow like here. So it is greater than minus 30 degrees, so it is left axis deviation. uh, so that inference you can put. Now we have already discussed about P wave, which is normal, and there is no AV conduction delay because the PR interval is also almost equal. But you see here a certain distinct morphologic changes you can find. Let me erase them all. So you see here, similarly in the same pattern you can see here, similarly another here and here. So you see here a different, distinct something you will be finding here. You see here. So you see here, this is Q and it is moving up, and you see here the ST segment here. So it is elevated. You see here the baseline here, PR isoelectric line. So I draw isoelectric line here. So this will be your isoelectric line somehow, isn't it? And you see, so here you see the difference here. So you see that the ST segment has been elevated and T segment is upright. So you basically see this morphology is especially seen in case of MI. So such distinct changes in lead V1. uh, if you draw a line here, so there is also slight ST segment elevation, but only one small square box it is occupying, so it's like 50-50. But in case of lead V2 and especially in lead V3 also, if you draw the isoelectric line here, and lead V4 also, you see in lead V4, and similarly in lead V5, you see that the ST segment elevation can be seen. In V6, it is normal, so there is no ST segment elevation. So you can say that, as we have already discussed in previous videos, if there will be any ST segment morphology abnormality, then there could be lead B1 or B2 MI that will suggest septal MI, and if there is only lateral B5 and B6, then it will suggest lateral MI. But you see here in this case, it is involving B2, B3, B4 and B5. So this is suggesting of anterior MI. So in anterior MI, if you see the inferior leads, that is lead 2, 3 and AVF, there could be reciprocal ST segment depression. However, so you see here in lead 3, you can see if this is isoelectric line, then some degree of ST segment depression and inverted T wave you can see here. Uh, in lead 2 there is slight, but it seems pretty okay, and AVF it is okay. So the basic fundi here is like it's an example of anterior MI, and since from B2, V3, B4 and B5 they are involved, a certain degree B1 also you can put it, so it's like extensive anterior MI. And and you can see that here in lead AVL there is also ST elevation, so lateral portion is also involved because AVL is indicating for lateral MI and B5 is also indicated for lateral MI. So basically there must be some occlusion in proximal left coronary artery, that is before the bifurcation of left circumflex artery could be. So while localizing, that could be the region. uh, However, there is extensive LAD occlusion, because some degree of septal portion is also involved, so it must be proximal. And and yes, this is the thing. uh, so this way we can conclude the MI. Thank you.